the Tranexamic arm of the study, on behalf of the principal investigator, Professor P.J. Devereux, and the POISE-3 investigators. Perioperative bleeding is a common complication in patients undergoing non-cardiac surgery. Tranexamic acid, an antifibrinolytic drug that may safely decrease such bleeding. In patients undergoing non-cardiac surgery who are at risk of bleeding and vascular events, we look to inform whether or not tranexamic acid reduces the occurrence of life-threatening, major and critical organ bleeding. And is non-tranexamic acid non-inferior for the occurrence of major vascular complications within 30 days compared with the placebo? This is an large international randomized controlled trial. We have a partial 2x2 factorial design. The patients on antihypertensive medication were randomized to the hypotension or versus the hypertension avoidance strategy. The BP result will be presented shortly by Dr. Celine Chia in the next presentation. This is the investigator-initiated blinded trial. The patients, healthcare providers, data collectors, and outcome educators were all unaware of the tranexamic acid treatment allocation. We included patients 45 years and older undergoing inpatient non-cardiac surgery who are at risk of bleeding and vascular complications. We excluded patients having intracranial surgery or cardiac surgery and planned administration of a systemic non-study tranexamic acid during surgery. Those with a creatinine clearance of less than 30 mL per minute or receiving chronic dialysis, we also excluded them. Patients were randomized to receive tranexamic acid 1 gram IV bolus or placebo at the start and end of surgery. All patients had troponin measured on the first 3 days after surgery. Study personnel followed patients throughout hospitalization and contacted patients at 30 days. 99.9% of participants completed the 30-day follow-up. The primary efficacy outcome at 30 days after randomization was a composite of life-threatening, major and organ bleeding, referred to as the composite bleeding outcome. The primary safety outcome at 30 days after randomization was a composite of mild cardiac injury after non-cardiac surgery, we call them MINS, non-hemorrhagic stroke, peripheral arterial thrombosis, and symptomatic proximal venous thromboembolism, we call them VTE, referred to as a composite vascular outcome. The primary hypothesis was that tranexamic acid would be superior to placebo for the composite of bleeding outcome. To satisfy the non-inferior hypothesis, the upper boundary of a can I say it again? The primary hypothesis was that the tranexamic acid was superior to placebo for composite bleeding outcome. As for the primary safety hypothesis, the tranexamic acid is non-inferior to placebo for the composite vascular outcome. So to satisfy the hypothesis of non-inferior to placebo, the upper boundary of the one-sided 97.5% confidence interval for the hazard ratio needed to fall below 1.125. The initial design was to randomize 10,000 patients, but due to the financial deficit resulting from slow recruitment during the COVID pandemic-19, the steering committee decided to stop recruitment on July 15, 2021, after at least 9,500 patients were randomized. The decision was made without knowledge of the trial results, but with the knowledge that aggregate composite bleeding and vascular outcomes were higher than originally estimated. This slide shows you the overall recruitment of POISE-3 patients. 9,535 patients were randomized in 114 centers in 22 countries. Most of the patients were from North America, Europe, and Asia Pacific region. This represents a very good global representation. In Malaysia, 6 hospitals participated in the POISE-3 trial. The centers were UMMC, General Hospital Kuala Lumpur, Sarawak General Hospital, Hospital Pulau Pinang, Port Dickson, and Sungai Buloh Hospital. These are the Malaysia contributors. The names highlighted in blue were the site co-PI, Dr. Chong, C.C. Chong and Dr. Ng Ting Yen from UMMC, Dr. Teo Su Jin from Sarawak General Hospital, Dr. Celine Chia from Hospital Kuala Lumpur, Dr. Lee Meng Lee from Hospital Pulau Pinang, Dr. Hema from Port Dickson Hospital, and Dr. Chiang Chun Fa from Sungai Buloh Hospital. On behalf of the POISE-3, thank you very much for all of you for your invaluable contribution. The baseline characteristic of the patient and type of non-cardiac surgery is shown in this slide. The mean age of the patient was 70 years and 50% were male. About 30% of the patient had history of coronary artery disease, 15% peripheral artery disease, and 8% had a history of stroke. 79% undergoing major surgery, which include major intra-abdominal, major vascular, major gynecological urology, and orthopedic surgeries. We had excellent compliance in both the tranexamic acid and the placebo groups. 96.3% of patients received both doses of the study drug. For the primary efficacy outcome, we are very pleased to inform you that tranexamic acid works. A composite bleeding outcome event occurred in 433 patients in the tranexamic acid group, which is 9.1%. And the composite bleeding outcome occurred in 561 patients in the placebo group, which is 11.7%. There's absolute difference of 2.6%. The hazard ratio is 0.76. The result is highly significant. The composite bleeding outcome event was statistically significantly lower in the tranexamic group compared to the placebo group. There's no significant effect of blood pressure study intervention on the tranexamic primary efficacy result. This slide shows you the Kaplan-Meier estimate of the primary bleeding outcomes. The hazard ratio is 0.76. It shows the two curves diverge relatively quickly early, which favored tranexamic acid over placebo. With respect to the primary safety outcome, a composite vascular outcome event occurred in 649 patients in the tranexamic group, which is 14.2%, and 639 patients in the placebo group, which is 13.9%. There was a total of 1,288 events, with only 10 events difference between the two groups. The hazard ratio is 1.023. The 95% confidence interval is 0.91 to 1.142. And the non-inferiority p-value was 0.04. The upper boundary of our 95% confidence interval was 1.142 and was above the non-inferior threshold of 1.125. The non-inferiority was not established for the primary safety outcome. This figure shows the Kaplan-Meier curve for the composite vascular outcome. The curves almost superimposed on top of each other throughout the duration of the trial. Based on the composite vascular outcome result, the hazard ratio of 1.023, 95% confidence interval of 0.19 to 1.142, there is a 95% probability that the primary safety outcome hazard ratio is less than 1.125. and 4.4% probability that the hazard ratio is more than 1.125, only 4.4%. Although we didn't meet our non-inferior threshold, the probability suggests it will probably fall below the non-inferior threshold. With respect to the secondary bleeding outcomes, BIMS, which is bleeding independently associated with mortality after non-cardiac surgery, which occurred in 416 patients in the tranexamic acid group and 541 patients in the placebo group. And with respect to the major bleeding outcomes, occurred in 363 patients in the tranexamic group and 496 patients in the placebo group. The BIMS and major bleeding was highly significantly reduced in the tranexamic acid compared to the placebo. With respect to the secondary vascular outcome, means not fulfilling the definition of myocardial infarction, and the net risk-benefit outcome composite of vascular death and non-fatal life-threatening major or critical organ bleeding, means stroke, peripheral arterial thrombosis, and symptomatic proximal VTE. We have demonstrated there was no difference between the two groups. With respect to the tertiary bleeding outcome, major bleeding, according to the International Society of Thrombosis and Hemostasis, it occurred in 315 patients in the tranexamic group and 415 patients in the placebo group. Transfusion of at least one or more unit of the packed red RBC occurred in 449 patients in tranexamic group and 574 in the placebo group. The results are highly significant for bleeding and transfusion, which is lowered in the tranexamic group compared with the placebo group. Looking at the tertiary mortality and vascular outcome, there's no difference across the treatment groups and placebo. Other tertiary outcomes looking at acute kidney injury, new renal replacement therapy, seizure, sepsis, infection, and sepsis. Again, there was no difference between the two groups. The pre-specified subgroup were defined according to the type of surgery, orthopedic versus non-orthopedic. Hemoglobin level of less than 120 grams per liter versus more than 120 grams per liter. Baseline estimated glomerular filtration rate and baseline NT-proBNP. The results of the tranexamic acid compared to the placebo on the primary efficacy outcome were consistent across the pre-specified subgroup analysis. Post-hoc analysis were generally consistent across all major surgical subgroup. We look at the pre-planned subgroup for the primary safety outcome. Again, we saw that the result of the tranexamic acid compared to placebo on the primary efficacy outcome were consistent across the pre-specific subgroup analysis. Post-hoc analysis were generally consistent across all the major surgical subgroups. We also look at transfusion of 2 units of packed red blood cell or more. You can see 296 patients in the tranexamic acid group and 396 patients in the placebo group. And the transfusion of 2 to 4 units of packed red blood cell.
There were sorry, can we wrap it up, please? Thank
23 you. Units in the additional in the tranexamic group and 312 in the placebo group. This was highly statistically significant. In conclusion, among patients undergoing non-cardiac surgery, tranexamic acid reduced risk of composite of life-threatening major and critical organ bleeding. Although tranexamic acid had no significant effect on major vascular complications, non-inferiority was not established. Our results also demonstrate 95.6% probability that the primary safety outcome hazard ratio is less than 1.125. What's the implication? Healthcare providers and patients will have to weigh a clear benefit reduction in composite bleeding outcome and absolute difference of 2.7%, against a low probability of a small increase in risk of composite vascular outcome, an absolute difference of 0.3%, which may or may not be significant. So this is the last slide. Majority of patients having non-cardiac surgery do not receive tranexamic acid worldwide. Annually, global shortage of 30 million blood products. Surgical bleeding accounts upwards of 40% of all transfusion. Given that 300 million surgeries occur worldwide annually, Point 3 identified that the use of tranexamic acid could avoid upwards of 8 million bleeding events, resulting in transfusion on an annual basis, indicating potential for large public health and clinical benefit if tranexamic acid becomes the standard practice in non-cardiac surgery. Thank you for your attention. And the result of this has been published in New England Journal of Medicine in April this year.